Okay. Right. So we will start. Right. So yeah, the last lecture, I try to explain the gastric secretions mainly. So then I explain about the three phases: cephalic phase, influence, gastric influence, intestinal influence. And so I explained about the acid secretion by parietal cells. What are the factors that stimulate? And from a vagus nerve, gastrin from G cells, and then a histamine. Then I explain factors that control the G cells. Same diagram, you can see here gastrin secretion from the G cells, and there are some other factors, stimulatory and inhibitory factors on G cells. And especially there's some other cells, D cells, which secrete histamine, somatostatin will act as an inhibitor. Then I explained about the what happened inside the parietal cells, H plus secretion, H plus pumping as a active pump, we call proton pump, HTP dependent, that means energy dependent pump. And then bicarbonate will move out to the blood with the production of H plus, and then chloride move, so we get the HCl secretion. Today I will explain the mucosal barrier function. So that means since we produce a lot of HCl, then it's very easy to get destroy the internal epithelium or internal cell layer of the stomach. To prevent that, we have very good barrier, protective layer, consists of mainly bicarbonate and mucus, right? So it mainly consists of bicarbonate and mucus. So in this layer, this is the gastric lumen. We have HCl, secreted HCl. Below that, we have mucus barrier. So these are the epithelial cells. So in this barrier, you can see a lot of mucus. Mucus means basically watery medium plus bicarbonate, right? So these are the cell layer, right? Epithelial cell layer, uppermost cell layer of in the stomach, and there's a tight junction between cells, right? So I hope you learn about the tight junction in histology. So those are junctions very tightly bound. Very tightly, cells are binded by this junction, so it will not allow things to move into the deeper. I mean, into the cellular side or into the inside of the gastric mucosa. So we have tight junction and secretions from these cells which contain mucus and a lot of bicarbonate, right? So this mucosal protective barrier will do a very big protective functions. If there's a damage to this barrier, we will get the ulcers or gastritis or peptic ulcers. Common reason is for the peptic ulcer is damage to this barrier. Right. So it protective barrier contain mucus and bicarbonate. Mucus from many cells, including neck cells of the gastric gland and other surface cells. Bicarbonate also secreted from surface mucus cell. Prostaglandin stimulate production of mucus and bicarbonate. So this production of bicarbonate and mucus stimulated by prostaglandin. So therefore, prostaglandin is important substance to maintain this layer or this protective layer. If we inhibit the prostaglandin, probably production of mucus and bicarbonate will be impaired. We might get the gastritis. Some drugs which inhibit the prostaglandin, right? Some painkillers, probably you have heard diclofenac sodium, ibuprofen or brufen. And these drugs are known to inhibit prostaglandin and then uh, probably impair the production of mucus and bicarbonate, and so we might get the gastritis. So that is why some drugs, especially painkillers, will make gastritis. Then trefoil peptide, other substance that will also help to stabilize mucus bicarbonate layer. So that is the third substance other than the bicarbonate and mucus important for the protective, for this protective barrier, right? So, of course, you will learn about the peptic ulcers, so gastric ulcers in a tutorial, but I will briefly go through this these few slides. Peptic ulcers are the ulcers due to excess acid secretion. So we don't call it a gastric ulcer, but mainly we call it a peptic ulcers because it's occur not only in the stomach, it occur in the duodenum also, right? So that is very important to remember. Gastric ulcer, oh sorry, peptic ulcer will occur in the duodenum also, right? Probably more than the stomach, it will occur in the duodenum. So therefore, probably we call it a peptic ulcer collectively. Uh, uh, acid acid making ulcers because of the acid secretion no impaired of this protective barrier, we will get peptic ulcer. It's very common. I'm sure some of you have uh, peptic ulcer, or you had some peptic ulcer in once in your life. So it's a very common disease condition, right? So contributing factor, alcohol, smoking, very known contributing factor. Then the fatty meal, fat contained meal might, or spicy meal like some chili, other a lot of spice or chili mainly might make contribute to peptic ulcer other than the alcohol and stomach. Uh, in addition to that, you will probably learn in your tutorial, there is a bacteria called Helicobacter pylori, right? So read it's even in the mention in the Gannon. Helicobacter pylori, it's a bacteria that also contribute to a peptic ulcer, right? So it was invented about 20 years ago, Helicobacter pylori and its contribution to gastric ulcer, and it's a contributing factor. So this invention of Helicobacter pylori won the Nobel Prize in about 10, 15 years ago. No, maybe 20 years ago. Right. So as I mentioned early, some drugs which will inhibit the prostaglandin, known as a group NSAID, non-steroid anti-inflammatory drug, which will inhibit the prostaglandin production, uh, uh, will uh, will make will contribute the will contribute to gastric ulcer. Then some drugs, some actually with this NSAID block the COX-1 function. That is the problem, but we have some not new painkillers we call COX-2 inhibitors, celecoxib, etracoxib, like new non-steroid anti-inflammatory drug, which will not block the COX-1, will block the COX-2, will contribute less for the gastric ulcers or peptic ulcers. And these newer drugs are popular because of they will contribute less for the peptic ulcers. Right. I hope you will learn this peptic ulcer and their contributing factor in your tutorial. There's a condition called gastrin secreting tumor. So it's a tumor that will secrete gastrin, right? So what is the function of gastrin? Gastrin is a hormone. Yes. So I explained in the previous lecture. So what is the function of gastrin? Yes, anybody? What's the action of gastrin? Yes, that's something I explained in the previous lecture. about gastrin. At least you should have something to say. Anybody? Okay, I will give 2 minutes. Just read some.
The hormone that stimulate gastric production,
It stimulate.
gastric acid,
Yes, yes, it stimulate.
gastric acid production.
Yeah, stimulate gastric acid production. Okay, good. So if there is a gastrin secreting tumor, what will happen? What will be the result? If there's excess production of gastrin. Yes. What can
The
happen?
damage to stomach wall,
Sorry, if there's excess production of gastrin, what will be the consequences?
it will damage the stomach wall.
Yes, it will damage the stomach because of the excess acid secretion. Yes, very good. Okay, right. So if there's a excess acid secretion, right? So pH will change, right? We get the acidic pH because now it's a tumor. Uncontrolled gastrin secretion and uncontrolled acid secretion, right? So pH will be acidic, and even the pH of the chyme mean content that come to the duodenum will be acidic. Okay. So then what can happen? If there's an acidic pH in the duodenum and small intestine, what can happen? So usually pH is in the duodenum and small intestines alkaline. If there's an acidic pH, what can happen? මොකද වෙන්න පුළුවන්? Anybody, any guesses? නිකන් හිතලා කියන්න පුළුවන් ඒවා පොඩි කනාෂොට් වගේ ඒවා.
Enzymes are inactivated.
Yes, exactly. So enzyme that secrete from the pancreas mainly will be inactivated because those enzymes might need alkaline pH. Now the pH is acidic because of excessive acid secretion from the stomach. So some of these enzymes, which especially lipase coming from pancreatic juice will be inactivated, will not act. What is the function of lipase? Lipase act කරන්න මොනවා මතද? What's the action of lipase? Carbohydrate, protein, fat. මොකද lipase act කරන්නේ? ඒවයි. Fat, yes. Fat කියලාද කිව්වේ? දැන් ඔය මොකක් හරිද? Right, yes. So fat digestion will be impaired in the gastrin secreting tumor because of this pH, bad pH or pH which is not appropriate for the action of lipase. So if there is excessive gastrin secretion, we might get poor fat absorption because of this inactivation of lipase due to pH alteration. So that's a big problem. Other than the peptic ulcers in the gastrin secreting tumor, fat absorption also will be impaired, right? So that is something you can remember or you can work out. Right. So treatment that inhibit the acid secretion. So as I mentioned earlier, it can block the proton pump. That means H plus secretion, ATP dependent process. Yes, this thing. Some drugs will block this. We call proton pump inhibitors, right? Very commonly, that omeprazole, pantoprazole, esomeprazole, those drugs will block the acid secretion and reduce acid production. And then some drugs will block the histamine receptor. Probably you remember the one receptor is a histamine receptor that stimulates the secretion of acid. So that cimetidine, ranitidine like drugs will block the H2 receptor, and by that way also it inhibits the acid secretion. Then if we thinking about the Helicobacter pylori, so that's a bacteria. I mentioned that. So probably we might use some certain antibiotic to destroy the bacteria, right? So then there are some drugs which will increase the neutralize the acidic medium. We call antacid, right? That will neutralize the acid in the surface of the stomach. We call antacid, aluminum hydroxide. That many syrup that we use for the gastritis contain antacid that will neutralize the acidity in the mucosa, and some of these syrup contain some sort of anesthetic like drugs which will prevent the which reduce the pain created by the ulcers, right? So these are the treatment, and probably again you will learn them in your tutorial, right? So later try to respond or try to answer to this question: what are the regulatory mechanism of gastric acid secretion, right? So I explained with details, steps, types, and regulation. If gastric acid secretion due to long-term, if the gastric acid secretion increase or reduce for a long time, what are the consequences, right? Right. Of course, sometimes acid will destroy the bacteria, right? So some infection, bacterial infection can be increased if somebody inhibit acid secretion for long period, then that is one possibility. Right. Of course, if the acid secretion increase, you get the peptic ulcers, and if especially gastrin secreting tumors might alter pH and so on. Right. So read these in leisurely and search internet or other sources. Right. So then I move to the motor function. Right. Motor function or muscle action of the stomach, right? So far up to here, I explained about the secretions and regulations associated with the secretion and consequences of these secretion like peptic ulcers and so on. Motor function mean, you can understand, motility, movement of stomach, right? Right. So three main function of the stomach related to motor function, right? So it will act as a storage of the food. So we know that we get a very considerable large amount of food, right? Then on a bad karnakota, everything will go and fill somewhere, need good storage. So stomach is the storage. Stomach is distended, right? So distension of stomach will feel as a you get the feeling, and even externally you can see කෑවට පස්සේ පේනවනේ තඩි බඩක් එනවා, right? So that is due to storage in the stomach. So usually stomach is if there's no food, it's something like this, but if you get a good meal, it can make something like this, right? So it's the storage function. Then mixing of food, right? So of course it will act as a storage, and then it helps to mix the food, especially with the gastric secretion, acid, pepsin, hormone, and any other, enzyme and any other enzyme, and of course a lot of mucus. So this mixing is important, and so this wall will make a rhythmic movement. We can call it a peristalsis, and that will mix the thing inside, right? So mixing is important. So mixing, of course, with the mixing, digestion will start, right? Fat digestion, protein digestion, especially with the pepsin. So digestion will start, and of course, some carbohydrate digestion because some amylase from the saliva and so on. So some sort of mixing and partly digestion started in the stomach, right? So when the food come to the stomach, it's a food. Like we just eat and teeth will break them to a mix with saliva and just still we call it's a food. But when it come out, it's not really food because of the mixing and partly digestion. We call chyme, right? Things coming out from the stomach we call chyme. So it's some sort of semi-solid material, right? Semi-solid material mixed with the mucus, more watery material, chyme, right? So this chyme, when it released to the duodenum, it will be released in a very regulated manner by this valve here, right? Gastroduodenal valve, right? So slow emptying also is a part of the function of the stomach. Slow. When we get the food, quickly fill. But it keep the storage and gradually release into the duodenum. Gradually. It's a very small amount at once. Because if it is large quantities come to the duodenum and small intestine cannot handle. Right? So storage and slow release also important. So in the stomach, storage important, mixing is important, right? So mixing like this and slow emptying is important, right? Slow emptying. These three motor functions are the motor function or movement action of the stomach, right? Okay. So we will see the regulation of these functions. So these are the three motor functions related to stomach. Okay, right. Right. So storage function, right? So as you can, I already explained, you can see the stomach is something like this when it is empty. Ari, kanna kittu enakota dawal එක දෙක විතර වෙනකොට probably it's something like this, very almost empty. But with the food, it can expand like this, right? Actually, this expansion is some sort of relaxation of the stomach wall, right? It relaxes the stomach wall and allow for the storage, right? So that relaxation we call receptive relaxation. Receptive mean reception. It's like a reception. It's like a reception for the food, right? So stomach will relax and that we call receptive relaxation. So receptive relaxation also a reflex, right? So when the food touch in this wall, right? When the food touch in this wall, some afferent information will go to the brain. Let's say these are touch receptor or pressure receptor, will send impulse to the brain, and brain will send impulse to the stomach, wall of the stomach. That is, this is afferent, this is efferent, and stomach will relax. So this afferent will go, of course, this autonomic neuron. Afferents will go through which nerve? What's the main nerve that connects stomach to the brain? Got the nerve. So I explained about the gastric secretions. Yes. What's the nerve or cranial nerve that connects stomach to brain? Vagus nerve. Vagus nerve. Yes, correct. So this afferent go through the vagus nerve, and efferents also come through the vagus nerve. So therefore, this reflex also vagovagal reflex. This also vagovagal reflex. In this about secretion also I explained about the vagovagal reflex, right? For the when the food touch the stomach, in the gastric phase or gastric influence, under the gastric influence, I explained about the vagovagal reflex for the secretion of gastric secretion. And here about the relaxation of stomach, that also vagovagal reflex. And you will learn some other places also vagovagal reflex. As example, for the contraction of the gallbladder, you also will act as a vagovagal reflex, right? And in addition to that, this is the reflex operate through the brain, but locally also some intrinsic reflex will operate in the stomach to relax the stomach wall, right? So in addition to this, some reflex will operate locally, right? And this will be afferent, and efferents will locally operate. This afferent and efferents on the smooth muscle, and this is the local operating reflex. We can call intrinsic reflex. That also facilitate the relaxation of the stomach, right? Right. So that is receptive relaxation, right? Important for the storage function. Otherwise, ඔයගොල්ලන්ට ඔච්චර කන්න බෑ. ගොඩක් කන්න පුළුවන් වෙන්නේ මේ රිෆ්ලෙක්ස් එක නිසා තමයි. එහෙම නැත්නම් බඩ ඉක්මනට පිරෙනවා ස්ටොමක් එක. If the stomach does not relax, we cannot eat this much. So therefore, if somebody want to reduce the eating, you know, the people who eat and get obese, or maybe that's not really their fault, some hormone imbalance and so on. So to control that, sometimes we cut the part of the stomach. Very popular surgery nowadays. We cut the part of the stomach. Let's say we cut something like this. So we remove this. I mean, the different type of surgery. So then we have a very small stomach. We can retain only, storage is limited, right? We cannot eat too much. So that is popular surgery nowadays. It conduct in many places in this country. Read about that in the internet, you can search. Right. So food in the stomach, mix this food with the weak peristaltic contraction wave. Contraction wave move toward the antrum. That means lower part of the stomach we call antrum. And then there is something called antral systole. It's something like, probably you know the systole of the heart. It's something like that, right? There is a contraction in the antrum and expel small amount food to the duodenum. Contraction of the stomach. It's a wave occurring every 3-4 times per minute, and small amount will move to the duodenum, right? So therefore we call this antral systole. It's a, you know, in the systole we push, the heart will push blood to the great vein, aorta and so on. So like that, in the contraction of the some part of the lower part of the stomach also will move small amount of chyme to the duodenum, right? Right. So emptying, as I mentioned earlier, is a slow process. Very small amount will push to the duodenum, right? Each time peristaltic wave pass to the antrum, small amount will open and chyme will go to the duodenum. Pylorus is that valve we call pyloric sphincter or pyloric valve, opening very small, only few millimeter or less content will expel to the duodenum, right? So you can understand very small amount, few milliliter of chyme will go to a duodenum at once, very small amount, right? Antrum, that means lower part of the stomach, pylorus, and upper part of duodenum function as a one unit. So that is very interesting. So let's say this is stomach, and this is antrum, and then we have pyloric sphincter, and then we have duodenum, right? So this is the, we can call pyloric sphincter, pylorus, and then the upper part of the duodenum, right? So this part, this part, this part will act as a one unit, right? So contraction with this place, and this place will push the food to down, right? So it's very interesting that sometimes things can regurgitate, go up. To prevent that, contraction of this third part, that means upper part of the duodenum, will be slightly longer than the contraction of this part. So therefore, things will move really downward and will not come back. Right? So I will explain it again. So this is antrum, part of the stomach. This is pylorus, pyloric sphincter, and this is the upper part of the duodenum. 1, 2, 3. So they three part of these will act as a one unit. That means coordinated action. And contraction will push chyme to the duodenum. When it contract, this last part, duodenum contraction, will keep longer period contracted than these two. So therefore, things will not really come up. Chyme will not come up because of this part contraction slightly longer than other two. So things that will make sure really things will move down to the duodenum. Right? So so this action is very important for prevent the regurgitation of things upward, right? So remember that they will act as a one unit, and really coordinated contraction prevent moving of things upward. Right. So emptying of stomach, food rich in carbohydrate leave stomach, leave the stomach fast. Food rich in protein rich food leave slowly. Fat the slowest, right? So if you think about the emptying, right, the fat will empty very slowest, and carbohydrate probably quickly, and protein then. So that is why you know that if we get the fat rich food, right, tel වැඩි කෑම, ගොඩක් තෙල් සහිත කෑම. So when we get the fat content food, probably we feel the tight fullness for longer period, right? And it will keep fill or full. හරි? බඩ පිරිච්ච ගතිය ගොඩක් වෙලා තියෙනවා when we get the fatty meals compared to other normal meals, right? වැඩිපුර තෙල් සහිතව කෑම බඩ ගොඩක් වෙලා පිරලා තියෙනවා. So probably you have experienced that because emptying of stomach slowest with the fat content food, right? Right. So then there is a osmoreceptor in the duodenum, and that also important to initiate gastric emptying. If the duodenum get a lot of chyme, and osmoreceptor will detect that will probably decrease the gastric emptying and control the things coming from to the duodenum. Because as I mentioned earlier, duodenum is not a storage organ. It should get the very small volume of chyme for their action. Duodenum and small intestine, enzyme action, mixing and absorption, everything. So therefore, it is very well control the emptying of stomach, right? The action of pyloric sphincter, this hormonal regulation, osmoreceptor in the duodenum, everything is important for that function. And for this regulatory action, neural, now mediated regulation, and hormone mediated regulation. I already explained about the gastric inhibiting peptide, somatostatin, and those hormones are important to control the inhibition of the stomach, right? So especially gastric inhibiting peptide, it's very important hormone that inhibit the gastric emptying. If the chyme get lot of, if the duodenum get considerable high volume of chyme, that will inhibit the emptying of the stomach, right? Right. So gastrectomy, as I mentioned earlier, it can be due to malignancy or tumor in the stomach, or maybe for the reduce the weight of the person. Partial gastrectomy is possible, right? If, of course, if there is a tumor or something, a complete gastrectomy also sometime will occur. But if there is a gastrectomy, we can get condition called dumping syndrome, right? So dumping syndrome is due to quick absorption of content from the duodenum. So let's say we have small stomach, and this is duodenum and small intestine. So since it's a small size and we cannot retain large volume in the stomach, so things will quickly come to the duodenum. So large volume of food will come to the duodenum. Then, of course, duodenum is not designed to handle the large volume of chyme or food, and we get the condition called dumping syndrome. So what happens if we get large volume of chyme into the duodenum? Osmolality of duodenum will increase. You know what is osmolality. If the osmolality increase, water will come to the duodenum. Large volume of water will come to the duodenum because increase osmolality in the inside the duodenum. So if the large volume of water come to the duodenum, even our blood pressure will reduce because of the accumulation of water in one place in the duodenum, right? So we can get the hypotension. Pressure will reduce, right? BP will reduce because of the accumulation of water. If we get the considerably high meal, heavy meal, after 30 minutes or 1 hour, blood pressure will reduce because of the accumulation of water here. Then digestion will start. Of course, large volume to digest, and carbohydrate will digest, and with the digestion, large amount of sugar will absorb, glucose will absorb, right? So now, compared to normal person, suddenly we get the high glucose load to the blood. If there's a high glucose load into the blood, what hormone secretion will increase? What is the hormone important to reduce the glucose level? මොකක්ද sugar අඩු කරන hormone එක? අයියෝ මේ පාර යන කෙනකින් හවත් කියයි ඒක. Insulin, yes. So insulin secretion will increase. Suddenly we get the increased insulin secretion from the pancreas because of the high glucose level in the blood. So insulin quickly activate and put this glucose into different cells, liver and other cells, and after some time blood glucose level reduce because of the high insulin action. After 2-3 hours, right, glucose level will reduce. This will occur in 30 minutes to 1 hour. Blood pressure will reduce. So after 2-3 hours, glucose level reduce. Our blood glucose level will reduce in our body. So this we'll call dumping syndrome. This part we call early dumping. This glucose part we call late dumping. Right. So that is something you can read in the GAN. I think it's mentioned in the Gannon and other textbooks about the dumping syndrome. Right. That is very important condition, especially nowadays. This removal of stomach is common. Partial gastrectomy is common. So people might get the dumping syndrome. Right. So these are the features of dumping syndrome. You can leisurely read as a consequences, we get the hypotension and hypoglycemia because of high insulin secretion. And of course, we can get the diarrhea because of the high osmolar things in the duodenum, small intestine. So, and some gastrointestinal symptom we might get in the dumping syndrome, right? Read about this and try to understand. In addition to that, those function, you need to remember stomach will secrete vitamin B12 absorption factor. We call intrinsic factor, right? Intrinsic factor is secreted from the stomach, and that will bind with the vitamin B12, and absorption will occur in the small intestine. And if there's a damage to the stomach, intrinsic factor we don't get the intrinsic factor like partial gastrectomy or one disease called pernicious anemia, where autoimmune destruction of parietal cells, because parietal cells is the cell that secrete with intrinsic factor, and they will get the B12 deficiency and special type of anemia. You learn in the blood module, B12 deficiency associated with anemia. Intrinsic factor is the important factor, and pernicious anemia is the condition. So that is not megaloblastic anemia. So of course, that is a type of megaloblastic anemia, but pernicious anemia, the word we commonly use for the destruction of parietal cells, right? So that's it about this lecture, and it's almost 45 minutes. So any questions you can ask? If there's any questions, please ask now. Yes? Okay, so if not, I will stop now and have a nice day.